I'm Jenilyn Mayu. I am a nurse practitioner at the University of Utah in Salt Lake City, Utah, and I am here today at the APAPP Conference in Las Vegas with my good friend, Melissa.
Hi, I'm Melissa Wilson, nurse practitioner at Advent Health in Orlando, and I am the Pulmonary Hypertension Program Coordinator and the Advanced Practice Provider Director for Heart, Lung, and Vascular Services. And we are at APAPP in Las Vegas.
We are. What do you want to talk about today, Melissa?
I think today we should talk about optimizing PAH therapy, right? So our field has progressed so much in my tenure. We've had a lot more treatment options available, different routes of different medications. So let's talk about optimization of PAH treatment. Like, what does that mean to you?
I love it. I think it's a hard question to ask and to answer because what does an optimized patient look like? Unfortunately, despite all of our treatments, our patients still progress downward, right? It's still a progressive cardiopulmonary disease without a cure. But I think we have a lot of opportunity to try to optimize those patients, and maybe optimization has to be personalized. What do you think?
I do think that I always feel like in PH, we always have these caveats, right? Nothing is truly algorithmic. And while we have guidelines that recommend dual therapies for some and monotherapies for others, triple in some cases, the one thing that's consistent is we know when people are high risk that parenteral prostacyclin is still considered the best treatment choice. But it's all very much not cookie cutter. It is going to be designed to each patient, their underlying issues, if any exist, what other therapies they may be on, and really even I think even now, really focusing on that shared decision making, like what do they want to do? Like what we may want as clinicians may be different than what they want as well.
I totally agree. The patient perspective matters so much, and I'm grateful that that's now more highlighted in our guidelines, I should say, because so many of our patients are just so different, right? We're hitting so many different ages, so many different spectrums, so many different socioeconomic classes that it's really hard to put everybody in one bucket, right? So parenteral therapy, I think, is one of the hardest therapies to optimize because there are so many patients that probably should be on them and could benefit, but we have a lot of roadblocks because of multiple issues, caregiver issues, living situations, drug use, so many things.
And that's really true. I remember when I started this in the past, I always tell patients, no matter what, I can always get you drug, right? And now it's not as easy as it once was to live up to that commitment, that promise. We do everything we possibly can. But like you said, so much goes into that beyond just access to it. It's the socioeconomics, it's the drugs, it's really the social determinants of health. Like you said, who's their caregivers, what their dexterity is like, all plays a role in it too. And the difference is they have options. Right? In the past, it really was, this is one inhaled option, one oral option, one parental options, and now you have far more.
And we're going from 6 to 9 times a day with one therapy to 4 times a day with Tyvaso, and we thought that was so amazing. And now we have these new, potentially once every 3-week therapies,
right?
That we're trying to learn and figure out together. And I know you have more experience with some of these newer therapies than I do. So I really look forward to trying to optimize the patients that I have that have just started sotatercept recently, that have been on parenteral therapies, that are bridging that gap between, living a good life and a lung transplant.
I think that's a great point. Really, where does sotatercept fit in? Is something I think is still yet to be determined. I can tell you where I know it does not fit in is monotherapy, right? It does not fit in when you talk about rescue drug. And I think that's going to be really important for those who are maybe newer to treating PAH to understand where that fits in. When you look at the data, it was studied with some type of background therapy, and some were on monotherapy with that as background, some on dual, and some on triple. And so I think what it gives us is some hope or opportunity that now we have a fourth treatment option. It's not a pathway. I don't think of it. I think more of it as like it's a biologic. So it's not really like a pathway like we think of with the prostacyclin, nitric oxide, and endothelial pathways. But we have this additional tool to add in to this patient's regimen to figure out, will it help optimize them? And then how do we define that again? Is that by the hemodynamics? Is it by their risk score? Or is it all the above?
I agree. And kind of taking this one step further, you and I both have a little bit of a different background bound by pulmonary hypertension, being that I practice on the pulmonary side and you practice on the cardiac side. But we get so many patients with so much mixed disease. So my question actually about optimizing therapy, maybe not in those who are already on triple therapy, adding a fourth therapy, is where do we stand with those patients that maybe we finally get to a point that we add one therapy and we try to PD5 and maybe they're getting a little better? Do we consider where their optimization is and where their side is? And I feel like we're getting more and more comfortable experimenting in that space than we have in the last 12 years.
And I think, it's hard, right? So I think when we think about those, we're really saying those people who have mixed PH pre and post capillary. What do those patients look like? Or those people who maybe have some lung disease and have PAH, and how we described it before, it's out of proportion to the other. It's hard because there's been many trials looking at patients who've been purely one or the other, purely group 2, purely, COPD, and have found that some of our therapies have been harmful for those patients. So I think this is really, like you said, going to that expert center, having that experience to finesse it and figure out like, hey, this therapy might be right for this particular patient. And maybe, like you said, are they symptomatically getting better? Are you seeing any remodeling of the right heart? Or is this even a bridge to something else? Like you said, bridge to transplant, for example. I think, our World Symposium for PH is next week. And I think it'll be interesting to see what kind of discussions also drive out of that conversation.
Totally, because I think so much of my PH world from the mentor that I had was amazing in saying this is a disease of exclusion. We've got to think through all the other causes of PH. So I almost think that optimizing PAH is really optimizing PH.
Correct. Right. Yeah, I think so too, because I think people we can look in the forest and miss the tree, right?
Totally.
Because if you still don't manage their underlying connective tissue disease, you're still not really optimizing that patient either. I think the hardest ones are now those PH-ILD, right? So now we have the treprostinil inhaled option for people who have combined pulmonary emphysema and pulmonary fibrosis, and those people who have interstitial lung disease, right? So being very specific at who this is for. It's not for the COPD patients. In fact, study was stopped early for those people. But for this particular group of patients to find that benefit. And we may see that their BNP may go down and their right heart might look better. Their walk distance may improve, but what doesn't really change is their shortness of breath. They're still short of breath. So again, optimization hemodynamically or physiologically may look different than really is that patient feeling optimized too. And that kind of speaks to quality of life.
Totally. And the personalization that this requires us to dig in and think further. And you've probably seen this as well on the cardiology side, is that we get patients referred for PH-ILD workups and we're ending up with high wedge pressures and giving them another heart disease, even though I'm a lung person, to try to just optimize their pulmonary hypertension in general.
Yeah. Well, what I love about PH is that I really think none of us are truly pure one thing, right? So we're all really truly cardiopulmonary nurse practitioners and PAs is really who I think we all are, because the heart is nothing without the lung and the lung is nothing without the heart. And when it comes to pulmonary hypertension, if those two aren't working in harmony, yeah, that's still in our space. And so I think that my upbringing, so to speak, is in cardiology, but I do have that multidisciplinary practice with that, including rheumatology with it. And we end up expanding into so many areas, renal management and all of these things as PH providers, that if you don't look at this from a personalized perspective, we're likely to do harm. We also realize these patients don't live in a bubble, right? They don't. How many people have you found nowadays that truly have one thing, that they are truly, that perfectly clean, so to speak, patient, where they don't have any other comorbid conditions? Those are hard to find.
They are. They're definitely a very small percentage of PH practice.
And I think that's some of what we see. I was recently doing a talk about looking at the hemodynamic changes and how the European guidelines had changed the hemodynamics, right? The mean PA pressure is greater than 20. Their wedge pressure is still greater than or equal or less than or equal to 15 for PAH. And then that PVR change, right? Being greater than or lower than 2 to determine if they're pre-post capillary or combined pre and post capillary, and looking at all these numbers, these three particular hemodynamic measurements to help us understand what group they're in. But when you look at those guidelines now, it'll say, okay, clearly this might be group 1 and 5. This could be group 2, 3, 4, and 5, right? It's like, so it's not as clean as it once is. And I think what that really does, though, is helps others understand that, like, without looking through all the other testing, like you said, it truly, I've been taught the same thing. It's a diagnosis of exclusion, right? If you don't look at those other conditions, you're going to put them in the wrong bucket, so to speak, right? You're going to classify them inappropriately. And then it's really even though the phrase of out of proportion is not really used, it really is what benefits you feel the patient will get from that therapy, and does that outweigh the risk?
Amen. I think we get to see our patients so much, right? We get to be really hands-on, and some of them we get to have these like decades of, or these years, almost a decade of having known patients, or even more in some cases, if they get to live that long. And I think it's pretty remarkable in how many are living that much longer, because, when I started 12, 13 years ago, it was, if your patient's alive after 5 years, it's probably not PAH, right? Now we're starting to find more of these patients and pulling them out of the weeds and treating them and seeing them. What do you find as sort of one of your biggest barriers in patients potentially getting to us?
I still feel like unfortunately, they're still misdiagnosed. They're still delayed, because I just don't know if people still look for the zebra enough, right? And it's still fascinating to me, and I think you see this as well, is they present with their historic data, and the evidence is there. And I've asked patients, like, why haven't, had anybody said this to you before? Anybody ever mentioned this phrase, pulmonary hypertension, before now? And sometimes the answer is yes, but they told me it wasn't bad enough. And I find that to be interesting. There's not a lot of diseases that we say, we wait for you to be very sick before we send you to a specialist, right? So take something like, if someone has COPD, we know they have COPD. You don't wait till they're like go stage 4 to be like, okay, now we're going to treat you. Let's take something like oncology. We don't go like, oh, that's stage 1 cancer. We're just not going to worry about that. We'll wait till you're stage 4. And I still feel like I think there's some of that misunderstanding, and maybe perhaps because the PH field continues to evolve and the needle keeps moving, it's making some challenges with that. But I think once you start with that suspicion of it, getting those patients over to the expert center would help us tremendously with capturing these patients sooner. I think that if we can really figure out why it's taking so long and what else can we possibly do to get these patients here sooner would be great. Maybe we need to be more intertwined in more guidelines in other areas, like intertwined in scleroderma guidelines, intertwined in chronic kidney disease guidelines, heart failure guidelines. Those are really common, or COPD guidelines. When do we, or interstitial lung disease? When do we really have that? Like, we really don't even have good direction in the ILD space when it comes to pH.
Right. It's still so gray. I have always loved here you sort of compare, not that we love cancer as a comparison, but the early stage with the late stage. And because pH, sort of taking this back, is such a sort of complex overlapping disease, I can understand the hesitation of, okay, there's mild pulmonary hypertension, but they have so many other things. Because we, of course, see the patients who have it. We don't see the hundreds who never made it to us that don't actually have meaningful PAH, right? That didn't need treatment in the same line. I could ask you questions all day, so I'm just going to continue to do that until you throw one back. Dun, dun, dun.
I can throw.
So let's say a patient finally gets to you, right? And you do your workup, and maybe they've been struggling with shortness of breath for the standard 3 years, and you're starting them on dual combination therapy. They're a clean-ish patient. What do you tell them to try to help them stay on therapy, stick with therapy? What's kind of your spiel to them?
So I tend to focus that around, I really intertwine the risk assessment in that, right? This is where you are in terms of your risk. This is where you could be in a year if we don't do something. Here's my goal. My goal is to get you to low risk. I want to get you to low risk because who doesn't want to live a longer, better life? Most everyone wants to live a longer life, right? And what about all the things that you want to do? I can't define that for you, but maybe those are things like seeing your grandchild graduate or watching someone grow up or spending time with your family. You have to define that for yourself. But with these therapies, it's my job to partner with you, help you through some of those things that are going to happen that may not be so pleasant with it. But we're going to partner together. We're going to be really good friends. So we're going to be closely following each other, really, and I also share a lot of my life with my patients too, right? Because as you say, you heard me use the cancer analogy before, because I am a cancer survivor. So I use those experiences to say, this is what meant a lot to me, and this is what you mean a lot to me as a patient, and that's why let's give this a shot together. And if it doesn't meet your needs, let's talk about what other things can. How do you approach that with your patients?
I just tell them what to do, and they do it, like all patients do. No, I think I like to bring it back down home. What do you like to do? Where do you want to go? Is it walking across the soccer field with your grandchild to get there? And we're going to start on these 2 medicines, and they may make you feel better initially. They may take a little while to make you feel better, but just stay on this journey with me. Stay on this trek with me, and then we'll decide sort of if and when we're going to add that third pathway, and I should say which pathway it's going to be along the line, but always taking it back to I can try to help optimize what therapies we can give them, but they have to optimize those therapies within their life, right?
Right.
Like we can't ask somebody to do something 3 times a day if they can't even get pills down once a day regularly.
Right. So I think you actually bring up some wonderful points. One, a new line. I had this experience talking to my son recently, and he has asthma. And I told him, your medicine doesn't work if it's not inside your body. And he's 12, and he understood what that meant. I mean, if you don't take your medicine, it doesn't work, right? No matter what, it'll never work. It's not inside your body. So there is that ownership that the patient has to take. But you bring up a great point about, we talk about dual therapies, triple therapies. Pill burden is a lot. And now we have a once-a-day combination pill. How do you think that's going to impact optimization of our patients?
I think that it's going to be helpful sort of on multiple fronts. Of course, we have such a financial tie to how well our patients can receive medication. So I think there is still going to be some benefit to it. Because those PD5s, even though they're cheap, some of our patients have really high copays. So that's probably the first sort of springboard that I have with patients of, hey, what are our copays, actually getting into the weeds and talking about? Because we know that family matters, money matters. This is part of this disease process, and these patients a lot of times feel that burden. But I think that lends to also potential improvement in care, but some of our patients split tablets. So we do a lot with medication, like, okay, take your ERA in the morning and take your PD5 if it's once a day at night, or maybe we're splitting and sort of playing with those timelines. So it'll be interesting to see as time goes forward, how many more patients are like, well, I'm going to just tolerate that headache and I'm going to take it at night or take it in the morning, and how much we actually do. And I feel that that's something really specific to APPs, how much time we can spend or how much time we do spend with our patients trying to get them through how to optimize the medications that they're on, timing. And then now that we have this combination pill, 1 pill once a day is great. You just can't forget to take it because then you miss 2 pathways.
That's a great point, right?
Yeah.
Exactly. If you miss 1 pill, you miss 2. You really miss 2.
Yeah.
But you hope that, that with once a day therapy that they would increase their reliability of taking it, because the great thing is it doesn't matter when you took it at that point, as long as you took it on that 24-hour period, right? And I do think the cost savings is something that we really can't miss. I commend the fact that pill is actually priced at the price of the ERAs, really making the price of the PD5 free. Yeah. So I think that's very helpful because every dollar does count. In every household. And so sometimes I remember when I did regular left heart failure, that you would have these medications that we say were $4, right?
Yep.
And you say, oh, $4, that's so cheap. But for some people, it wasn't. And I still remember a conversation I had with a mom who said $4 means the difference between feeding my son tonight or not. And that was really impactful. So I really feel like keeping the costs down and being very cognizant of that for these patients. They're living longer, and you want to be able to live and truly live. So you need finances to do that. So I'm glad that we have this as an option. And you're right, counseling and that support of all of it is going to be so important with keeping the compliance. And so I want to ask you a little bit more about the PH-ILD space, since you're so tell me a little bit about how you have seen patients optimize with the addition of having treprostinil in the market for that particular type of patient.
I think we all have those patients that have done well on it and they do feel better. And then we have those patients that we're just disappointed that that's all we had to offer them and they haven't succeeded on it. So I think we're still trying to figure that out of who are the right patients to be on, an inhaled treprostinil product versus those that are, not appropriate at all. You're right. Like we know with COPD it doesn't quite work and we see that combined, but sometimes I am pleasantly surprised. But I think we still have so much of a landscape to go with our ILD patients, and they are just desperate for anything. So anything we can do, I think it's worth a trying for. But there are patients that before we even get to heart cath, I will sit and talk with them, show them the therapies. This is the inhaler. This is the nebulizer device. Is this something that you can commit to? Because if you don't do it 4 times a day, every day, for potentially, a long time, then we're never going to know if this medicine really works. This is not a rescue inhaler. This is not something that's going to make you feel better tomorrow. And we know the cough is real. So once again, kind of bringing it home to optimizing pH by optimizing what our patients' expectations are and what their disease is the best that I think we have to offer at the end of the day. We pull out our toolbox and that's all we can do.
I agree. The optimization needs to be something that is it has a dual definition, our perspective and theirs as well. It's nice talking with you about this.
So good to talk with you too. Have fun at the conference.
You too.